Welcome to Nipped and Toxxed. I am Dr. Ashley Robey, your host. Today we're going to be talking a little bit about fat transfer. I know we covered this a little bit on my previous liposuction episode, but I wanted to get into the specifics about fat transfer. One thing that I learned early on in practice was to not call it free fat transfer. That term is used to describe the fact that fat is freed up from its native blood supply and then added to the area of interest. It's not free as in cost $0. So a little bit of confusion in the way that it can be described, but it is technically a free fat transfer, but unfortunately does not cost 0 cents. So fat transfer has gained a lot in popularity over recent years, and this is for, I think, many different reasons. One is primarily that patients seem to like the natural feel of it. In contrast to implants, for example, or even potentially fillers, fat is your own tissue. So it doesn't have anything that feels like something foreign. It feels like fat. And that is something that can be really attractive to patients. Another advantage of a fat transfer is that it's essentially a 2-in-1 procedure, meaning that you're taking fat from an area of relative excess and then adding it to an area of relative deficiency. So if you have, let's say, love handles or a little pudge in your thighs or abdomen that you would just assume not be there, and also you're wanting to add fat to the donor area, again, it's classically like the face or breasts or buttocks or hands, you will address both of those issues at the same time. Another nice advantage of fat transfer is the potential for the longevity of that treatment. With things like fillers or even implants, there's recommendations to change the implants out every decade or so, or in the case of fillers, they're not expected to be long-lasting or permanent in the case of things like hyaluronic acid or Sculptra, etc. So people like the thought of this being something that is a permanent enhancement of the area that's being treated. There's a reduced risk of allergic reaction, not specifically in the case of implants that we're talking about, but in some of the fillers, there is a chance that you could have an allergic reaction to one of the ingredients of the fillers. Of course, you will not be allergic to your own fat, so that's not really a worry that we would have for this procedure. Also, when you are doing a fat transfer, you can be introducing stem cell-like cells, in this case, progenitor cells, meaning they're one-step differentiated, and those particular cells can have a rejuvenating effect on the area where they are being transferred to, so that's a benefit. So what exactly is fat transfer? Fat transfer involves removing fat from an area of relative excess and then transferring the fat to an area of relative deficiency. So classically, the fat would be removed in the form of liposuction. Liposuction is a minimally invasive procedure where you are making small little incisions, you're suctioning out the areas of extra fat and contouring the donor area. All the fat would then be collected and processed. There are different ways to process the fat. Some surgeons will use gravity sedimentation, meaning allow the fat to settle and remove the inferior aqueous layer or watery layer and the superior oily layer. Some surgeons will centrifuge the fat. There are different techniques that can be utilized to get the most amount of fat that's healthy and ready to inject. The most popular areas for fat transfer are the breasts, the buttocks, the face, and the hands. Not specifically in that order, but I would say those are definitely the top 4. The nice thing about fat for the breast is that it can be used in lieu of an implant. A breast implant is something that's not considered to be a permanent lifetime device. It is recommended that you remove and or replace them every decade or so. So they do have a shelf life, so to speak. Whatever fat transfer you have added to your breast, that doesn't have a shelf life. So whatever fat survives is just fat that you have there. So just like you don't specifically do maintenance on fat in other locations in your body, there wouldn't be any specific maintenance required for the area where it's transferred, whether it's, again, face, breasts, buttocks, or hands. For fat transfer to the face, we've covered this before, but every decade that we age, we lose about 6 to 7 cc's of facial fat volume. So you are literally replacing exactly what you've lost. Fat transfer is a great way to restore some of that fat from our youth. I tell patients often, hey, take a look at a photo of you when you were in high school or in your 20s and compare it to your face now. And I suspect most people would find that their face is quite a bit less fatty or full as they have aged compared to the more youthful version. That being said, we're not trying to take you back to your toddler years where your face and cheeks were extremely pudgy. We're shooting for maybe 20s or early 30s with regards to that kind of ideal amount of facial fat. For the hands, again, as we age, we are losing some elasticity in our skin and we're losing some of the fat on the dorsum of the hands. So again, we're talking about the top of the hands, in between the bones, the metacarpal bones, kind of threaded in between some of those more prominent dorsal hand veins. We can add some of that volume so you can lose a little bit of that skeletonized look, meaning being able to see all the tendons and bones of the hands. When you look at look at a toddler's hands, they're actually pretty fatty. And as you age, you lose some of that fat in your hands. So a fat transfer can be a really nice way to replace some of that. For the buttocks, the Brazilian butt lift, which is also known as a free fat transfer to the buttocks, has been really popular over the years. I feel like the trend is a little bit less so to have the outrageously large buttocks that were popular for a few years back, but to more shape the buttocks. So improving the shape, getting rid of indentions, smoothing out contours. Some patients do have a little volume deficiency for sure. And so it's nice not only to shape, but to add volume. Some patients that have lost a fair amount of weight may find that they have almost no buttocks or very flat and deflated appearing buttocks. This can be seen a fair amount with some of the injectable weight loss medications like tirzepatide or semaglutide that people will talk about feeling like their buttocks are specifically deflated secondary to that medication. So this could be a nice option for those patients. One thing that I will also do for some patients that are really thin, if I'm removing areas of skin, we can also get really aggressive with regards to the fat removal for the tissue that is already being removed because it's not being kept and it doesn't have to have a normal layer of fat on it to look good. So we can get into that later, but that's another option for patients that are a little bit low on fat, like they don't have a lot of donor fat. That can be a good option for them. So when you do a fat transfer, unfortunately, not every single fat cell survives. The pretty well-established rates of fat survival are about 50 to 80%. Unfortunately, that means somewhere in the 20 to 50% range of fat is expected to not survive. There are certain techniques that the surgeon can use to try to optimize this, but the truth is that no matter whatever technique is utilized, it still doesn't mean that you will have 100% fat survival. When a fat transfer is done, again, I talked a little bit about this, it is freed up from its native blood supply. So if you're liposuctioning the fat, you're detaching it from its native blood supply in the area from which you are borrowing it. Then the fat has to be injected and it has to establish a new blood supply in order to survive. So you need to have a healthy tissue bed. Ideally, you have to have a good blood supply to the area. If there is not enough blood supply and those fat cells do not establish a new blood supply, the fat will be reabsorbed. So essentially it will be lost. Because we know that not every fat cell will survive, in many cases we will over-inject a little bit to account for this anticipated amount of fat loss. For areas like the face and the hands, you have to be a little more careful because you don't want to create a scenario where you've underestimated the amount of fat that would survive and then added too much fat because you don't want to create areas of excessive fat in the face or the hands for that matter. So things like having like overly puffy dorsum of the hands, or especially in the tear trough areas, those areas do not look good if they're overfilled. The breasts and the buttocks, however, are a little more acceptable of having an overfill, meaning adding a little bit too much volume. I would say, I can't think of anyone who said, oh, I wished I would have had you add less fat to my buttocks or breasts. I don't think that's a thing. And that's not because I add extreme amounts of fat or I don't add very much fat. It's just that, let's say the average fat transfer to the breast is maybe about a cup size bump from what you were. Obviously, you can add more fat to the buttocks just because the buttocks are bigger and there's more space to add fat. But yeah, I think it would be pretty atypical to have too much fat with a single fat transfer. Now, let's say you want to add more volume. Let's say after a single fat transfer, once everything has settled and you've established the final amount of fat viability and survivability, and you find from your perspective that it's not adequate, you can do secondary fat transfers. So you can do a series of fat transfers. If there is enough fat available, that is, you can do multiple fat transfers to whatever areas if there's enough fat. And so I suppose in those scenarios, you could find yourself being overfilled, let's say in the buttocks or the breast, but I would say not really a common issue with a single fat transfer. When the fat is harvested, the primary means most people are utilizing is liposuction. You are first injecting the area that is the donor site with a tumescent solution. The primary purpose of the tumescent solution is to reduce the amount of blood loss, but for some patients that are either partially awake or fully awake, the tumescent solution also contains numbing medication, which will help with comfort. Then you, as a surgeon, are liposuctioning out the excess fat. And so if we're not removing any of that tissue, obviously we can only take so much that the donor site still looks good. So at the end of the surgery, you still want every body part that was worked on to look better. There is such thing as over resecting fat. And as a surgeon, I certainly wouldn't advise that. I wouldn't make the abdomen, for example, look worse just so that the buttocks could look better. I don't think that's a reasonable trade-off. So there's I would say a maximum amount of fat that could be borrowed from any area without theoretically compromising the aesthetic outcome for that area. Once the fat is harvested, it is collected in a sterile canister on your operative field. Sometimes I will allow the fat to settle, meaning if I have other areas that I need to work on before I get to the fat transfer portion, I can let that fat settle and it will layer out. Classically, it would layer out with an oily layer on top, followed by a fatty layer, and then the aqueous or water layer at the bottom. The oily layer at the top and the water layer at the bottom are discarded, and then you're left with the fat layer that you can use for fat transfer. When I do large volume fat transfers, that is my preferred modality. If I am doing smaller volume fat transfers or in areas that are really sensitive to being overfilled, I will not overfill them. I will centrifuge the fat, meaning further removing any potential excess liquid or damaged cells. And that way I only have the most purified fat that I want to directly inject. And so that's the technique that I prefer for the face and the dorsum of the hands. When fat is injected, I like to think about the tissue that the fat is going into kind of like a 3D mesh, meaning we know that the fat cells are only going to survive if they establish a new blood supply. So if you think about your tissue like an expanding plane, you can inject fat in all those little spaces that you've created. You can't just make a big dollop of fat and add it in here. You have to inject it in all the little openings that you have created. So it's really important to spread the fat out, create little thin layers that are evenly dispersed across the tissue planes. Because if a large dollop is just added, let's say to the middle of the breast or to the middle of the buttock, all of the cells on the periphery are likely to survive because they are near blood supply. But the cells on the inside would not be near any tissue with blood supply, and so they would all die. So we don't want that. It's super important from a technique perspective that your surgeon recognizes this. Otherwise, you're going to run into problems with large areas of necrosis or really large oily cysts. That's not to say that these complications couldn't arise anyway. That is a theoretical risk of the surgery, but I would say it's more of a rare occurrence to have that problem than specifically having large volumes of substantial necrosis or oily cyst formation. So next, who is a candidate? The ideal body types for fat transfer would be patients that have some fat to transfer, right? So you have to have a little bit of fat available in order to do a fat transfer. close to your ideal weight, but despite that, still noticing that, hey, I've got a little pocket of fat here, I've got a little pocket of fat there. I wouldn't mind having those contoured and having that fat removed and then repurposing the fat. When I do liposuction for patients, I always ask them to consider it because we all have a finite amount of fat available. It's a limited resource. I mean, for some patients, more limited than in others, but once we discard it, it's gone. So I think it's worthwhile at least considering, and that's not me trying to like upsell patients, like don't do a fat transfer if you don't want to do a fat transfer. But if you think that there's an area that you do want to add extra volume to, obviously when you're doing liposuction would be the most appropriate time. You already have the fat, it's already there, it's ready to almost go, and you could add it to an area of relative deficiency. That would probably make more sense than, trying to add a bunch of fillers to your face or a bunch of fillers to your hands when you have your own fat sitting right there, that the portion of that survives is a permanent filler. So there's definitely some advantage to considering a fat transfer. The things that make a patient a reasonable candidate would be, one, again, fat availability. So do you have fat that can be transferred? Two, do you have reasonable expectations? If you say, for example, I want 500 mLs of fat added to each breast and I want it to all survive and I'm an A cup now, that's not going to be a thing. Like there just won't be enough space in your breast to get 2.5-ish cup sizes added. And so either in that scenario, you are considering something like a breast augmentation with implants, or, you could do serial fat transfers, but it's not super common for patients to be really excited about signing themselves up for a series of surgeries. Who is not a good candidate? So first and foremost, unfortunately, as in most surgeries, smokers. Smoking causes vasoconstriction in your little blood vessels. And so for fat transfer, again, it is of utmost importance that we get those fat cells to establish a new blood supply so that the fat can survive. If we add nicotine to the system and we take a blood vessel that's of this caliber and all of a sudden it's vasoconstricting or shrinking down to this caliber, those fat cells are less likely to establish a blood supply. So we don't want that. Patients that have just poor general circulation, meaning you have, let's say, peripheral vascular disease, that also would probably not be a very good candidate. Patients with just overall poor health. If you're not healthy enough to go out and exercise, you probably shouldn't endure the stress on your body associated with surgery. Also, patients that are planning on weight loss. That's a big one because I see a lot of patients that come in saying like, hey, I want to do the surgery, but I also want to lose 10 pounds or 20 pounds or whatever the number is. As a rule of thumb, the closer you are to your ideal weight and your preferred weight at the time of surgery, the better. So what you don't want to do is to go and have surgery and liposuction all the areas of relative excess fat, add it to whatever area you want to add it to, and then lose more weight. A fat cell is essentially like a storage container. So if this is your little fat cell and you are gaining weight, it's going to plump up. But if you lose weight, it's going to shrink down. So if we add all these fat cells, but then you've lost a bunch of weight and they all shrink down to the point where you can't really see them anymore, then the impact of that fat transfer is almost nullified. You don't want to go through a surgery just to negate the effects. Same thing with weight loss. Like you don't want to plan on a bunch of weight gain after surgery. That can impact not only the volume in the recipient areas, but in the donor areas. If you have a lot of weight fluctuations, that can affect the liposuction areas that have really smooth contour at one point. If you gain a bunch of weight, can look a little more irregular. The other thing that you would have to consider too is skin elasticity. This always comes into question when you're thinking about body contouring, is what are we going to do with the overlying skin? So if you already have poorly elastic skin and you don't want to do anything to tighten it and you don't want to do anything to remove it, just removing volume from that skin in the form of liposuction would certainly make that skin looseness worse. So I would not advise patients to exacerbate their degree of loose skin just to do liposuction and fat transfer. In those cases, you want to think about some way to address the skin as well. So for my patients, I will either recommend something like Body Tight, which uses radio frequency energy to induce a soft tissue contraction. So it's a minimally invasive way to tighten the skin, or skin removal. So things like an abdominoplasty, things like a thigh lift. And that can be a really nice option for patients that are also quite thin. So it's not uncommon for patients, actually did just the other week, upper back lift with a fat transfer to the buttocks. So what you can do is you can remove the area of extra tissue. So classically, a full thickness layer of skin and the associated subcutaneous fat. And then you close, obviously you're closing that off, but you, in that case, can take the skin and all the fat. You can take all of the fat, the whole layer of fat, and that fat can be available for fat transfer. Whereas, let's say you're just doing liposuction and you have skin and fat, you could just borrow a little bit because you have to leave a nice uniform layer of subcutaneous fat. Otherwise, it will look terrible. But if we're taking that out, if we're taking a wedge of tissue out, we basically have the piece of tissue on the back table, and we can get really aggressive with utilizing every little bit of fat cell that we have removed to be used for fat transfer. So that's something that I would do pretty regularly as well. So patients that are getting kind of a combination fat transfer with an excisional or traditional surgical procedure, that's a nice option. So after you've had your fat transfer, what should you expect? Immediate results versus long-term results. Right away, obviously, you're going to have a lot more volume in that recipient area than you will long-term. So in areas like the breasts and the buttocks, you may think, wow, this is great. This is so much volume. In the face and hands, you might think, I look kind of puffy and this looks a little bit crazy here. But the truth is that regardless of whether or not you like it or you think it's too puffy, all the areas will get less swollen and less full immediately following surgery. So right after surgery, let's just say 100% of the fat that was added is apparent from a volume perspective. You will also have a little bit of swelling, meaning let's just say you pass a cannula through the tissue and don't add anything, that trauma in and of itself will create some soft tissue swelling. So you'll have both of those components adding to a perceived increased volume. The swelling will kind of peak around day 3 and then subsequently continue to improve for several months. For a fat transfer, I would say somewhere in close to that 6-month window before we've seen the final impact of the total amount of fat that has survived. Again, the anticipated fat survival rates are around 50 to 80%. From a swelling and bruising perspective, the most of the swelling is gone, let's say in the first handful of weeks, but to a smaller extent, there is swelling persistent, I would say close to 9 to 12 months to a really small extent. Bruising, it depends if you're an easy bruiser or not. Some people bruise super easily. And so in those cases, if you have a lot of bruising, it can take several weeks to go fully away. And then it goes through all the rainbows of colors with dark blues and purples fading to light blue, light purples and pinks and greens and yellows, etc. The whole rainbow of colors. And if you get a really deep shiner, really deep bruise, those can take, 4 to 6 weeks to totally go away. Downtime wise, the most challenging area from a downtime perspective for fat transfer purposes is certainly the buttocks. So wherever you are adding fat to, it is not advisable to be applying direct pressure to the area. Think about, let's say you cross your legs, and then when you uncross them, you notice that all of a sudden that area where the two legs are touching is pink and flushed. That's because when you have your legs crossed, you've pushed all the blood out of that area. And then when you uncross them, that blood comes running back in. So what we don't want to have happen in a scenario where we're trying to get as many of those fat cells to survive as possible, we don't want to push all the blood out of the area. We want to have the best blood supply possible so that the fat cells can survive. So that classically means not applying pressure to the recipient areas. For the chest, that means not laying on your chest. That's usually not an issue for the dorsum of the hands, nor is it classically an issue for your face. It's not common for people to sleep face down. But let's say you did like to sleep on your face, or you like to sleep on the side of your face. I would advise against that in the beginning following surgery. For my buttock patients, that does become more of a challenge. So for the first 2 weeks following fat transfer to the buttocks, I recommend not sitting or sleeping on your buttocks at all. You can get creative. They even make little booty beds for patients that are recovering from fat transfer to the buttocks, where essentially you've got support on the lower back and you've got support on the posterior thighs, and the buttock is kind of scooped out where you're offloading pressure, and all the pressure is on the lower back and the posterior thighs. I can't attest to how awesome these beds are or not. I feel like they have mixed reviews, but that is a way that you can still sleep on your back but not apply pressure to your buttocks. Alternatively, you could sleep on your abdomen, so sleeping prone. That's certainly a way to offload the buttocks. Also, you wouldn't want to sleep on the side of the buttocks either, because that tends to be an area with a fat transfer to the butt that we are trying to add volume to as well. So yeah, the sitting restrictions are the biggest thing. I don't classically have a lot of patients feeling really bummed about not being able to lay on their chest or their face or the dorsum of their hands. That doesn't seem to be a thing. So how do you maximize fat retention? There are always things that, I as your surgeon could do, or whoever your surgeon is. There's things that they can do, and then there are things that you as the patient can do. So as a surgeon, we're trying to get the fat, like the most healthy fat available and purified, so that the space that we're adding volume to is primarily taken up by viable fat as opposed to non-viable fat or too much liquids. We talked a little bit about how layering the fat, not adding the fat in large dollops. When I do large volume fat transfer, I do use a technique called expansion vibration lipofilling. So essentially that utilizes a power liposuction handpiece. And then instead of sucking the fat in through the handpiece, I'm pumping it back out through the handpiece. And so the little tip is vibrating. So if you think about this is your tissue, like it's kind of like vibrating and then creating it. So it's expanding as it vibrates and creating these little spaces. Again, those are the spaces that we're wanting to utilize to add a little bits of fat to. So I feel like that is a really helpful technique, especially in some areas that are dense, like let's say the lateral buttocks, in that zone of adherence where it doesn't really want to spread out and shape into the exact shape that you as a surgeon wish you could create. Having that tool is really helpful so that you can create as round of a shape as possible. Those are the things that a surgeon can do. As a patient, the things that we already kind of talked about. So offloading pressure, so not applying pressure to those areas. Again, for me, first 2 weeks, not sitting at all. And weeks 3 and 4, I do 10 to 15 minutes at a time. That means you're still not sleeping on your buttocks for weeks 3 and 4. And then after that 4-week mark, you don't have any residual restrictions. Nutrition is always super important. I think from a caloric perspective, after any kind of surgery, your body actually needs more than the baseline amount of calories, because it needs just the base amount just to do all the things that it normally does, but it needs more to account for all the healing that it has to do because you just had surgery. Hydration obviously is important as well. Also, not smoking. So don't smoke. It's not good. Don't try to lose weight. I don't know what it is, but I see that not uncommonly, in that some patients will, I think they get really motivated because they see in that donor area, whether it's abdomen or thighs or wherever, that they're liking that decreased volume. And then I think that motivates them to want to take it to the next step. But certainly immediately after fat transfer or immediately after surgery is not the time to go on a weight loss plan. And that can actually be really problematic with regards to healing and really problematic with regards to fat retention. Risks and complications. The most common concerns after a fat transfer, I would say, are fat survivability. Again, about 50 to 80% of the fat is expected to survive. Fortunately, in my experience, I would say for, let's say, 2 buttocks that are roughly the same or 2 breasts that are roughly the same, they seem to have very similar survival rates. It wouldn't be common to be like, oh, well, that breast was 80% and that one was 50. I just don't really see that. I think that can come into play if the patient is doing something atypical, like, oh, well, I like to sleep on my right side, so I was laying on my right. I feel like that probably would impact the amount of fat survivability on that side. The more common scenario is just that if patient is starting off with notable asymmetry, like let's say their left breast is an A cup and their right breast is a C cup, you can definitely add a lot more fat to the C cup because there's just that much more volume, there's that much more space. Let's say I added 100 mLs of fat to one and 300 mLs to the A cup side, like the right side is still going to be bigger. So I think that's always a little bit of a guesstimate. You're trying to anticipate how much fat you expect to survive, but the fat survival percentage rates can be different if the starting point of the breast is different. Again, that's not like really common in faces. I mean, yes, faces all have asymmetries, but classically it's not to that percentage of difference. Like you don't have like, oh, this face is fat, super fat, and this side of my face is like Skeletor thin. That's not a classic presentation. But yeah, most people have some subtle volume asymmetries, and the goal for fat transfer is obviously always to make things more symmetric. But even with the best intentions, you're not going to end up with one side of the face looking exactly like the other. That's just not a reasonable endpoint. Lumps. So after liposuction and or after fat transfer, it's pretty common to have little lumps and bumps. Those tend to be pretty transient. If those little lumps and bumps persist longer than anticipated, your surgeon can attempt to aspirate them, like maybe one of them is an oily cyst, meaning some fat that did not survive, and instead of being viable and establishing a blood supply, it partially resorbed and then left a little oily cyst there. So that can be aspirated with a little needle in clinic. But yeah, just like you can have lumps and bumps after liposuction, you can certainly have lumps and bumps after fat transfer. That's not that atypical. A more serious risk would be something like a fat embolism. So again, with a fat transfer, you as a surgeon are wanting to inject the fat into a soft tissue plane without lots of big vessels. There was an advisory by the American Society of Plastic Surgeons that recommended that in the case of fat transfer to the buttocks, that the fat only be added into that subcutaneous plane. Meaning, just like we were talking about before, if you have a bigger space to add the fat, like muscle and fat, you can add more fat. So that is appealing. But in the case of that muscle plane, there's some really large gluteal vessels in that plane. And if the fat gets into those vessels, that can be life-threatening and dangerous. The ASPS, the American Society of Plastic Surgeons, has advocated for the surgeons to only inject fat in that subcutaneous plane, avoiding the fat in that muscular plane because that's where the big vessels are. So yes, maybe you aren't getting as much fat as if you were able to add fat to all that. That's okay. It's a much safer procedure, and that's how most surgeons do perform it in the United States. So fat transfer to the buttocks is only done in that subcutaneous plane. There are some other techniques that are employed as well to try to keep it as safe as possible. And that classically involves things like using larger cannulas. So if the larger blunt cannula has a bigger diameter than the vessel, then it's unlikely that you are going to enter into the vessel and inject fat into the vessel. Also, the system that is injecting the fat should be pretty low pressure, so not a lot of force behind that stream of fat. It's just kind of a low pressure system. If it's meeting any resistance, it wouldn't push past that and potentially get into dangerous spaces. So if fat does get into a large blood vessel, obviously the veins return blood back up to the core, and you can get a fat embolism, a piece of fat that's stuck in your pulmonary vessels that can impact the way that part of the lung functions and can even be life-threatening. And not something I've seen, but reported in literature. And again, all the things that are recommended to reduce the risk of that phenomenon are things that I employ in my practice, and I'm assuming most other surgeons employ in their practice as well, because we're all motivated to have good outcomes and have the best safety profiles possible. Another really important thing is surgeon choice. So having a board certified plastic surgeon that is aware of the things that I was just discussing, that knows what tissue plane they're in, that knows an ideal diameter cannula, that knows they're not in the muscle, that they're in the subcu fat, that knows that their pressure on injection is low. All of those things are important from a safety profile. And so having a board certified plastic surgeon is certainly going to increase the likelihood that those considerations are being taken into account. Okay, on to myths and misconceptions. Number one, fat transfer is permanent. So yes, fat transfer is permanent, but like we talked about before, not every fat cell will survive. So of the fat that survives, that fat is permanent. Of the fat that doesn't survive, obviously that's reabsorbed and is no longer present. Let's see, next, fat transfer is a safer alternative to implants. Yeah, I think it depends. There's something to be said, I think, certainly for the reduced long-term maintenance of a fat transfer. Whenever you have a breast augmentation, you go into that surgery, or at least you should, you go into that surgery with a mindset that, hey, this isn't the first and last surgery that I'm going to have on my breasts, because the breast implants are not permanent lifetime devices. Again, the rule of thumb for implants is to consider removal and replacement every decade. That doesn't mean you have to. That doesn't mean anyone's going to be knocking on your door telling you, hey, time to change out your implant. That's not going to happen. But you know they're not going to last forever. And I like to use the analogy, like I think about like when I walk around my shoes like all day, every day, just some of the wear patterns that you can see on the bottom of your shoe. The same thing holds true for an implant. This implant that's sitting on your chest every day, it's moving, you're breathing. It's another material. So they're both materials, and with enough movement and wear and tear, they will show signs of wear, meaning stress and eventually failure. So that 10-year mark for implants does coincide with their warranty, meaning that the implant companies would cover your implant cost and a majority of the costs associated with having them exchanged should you have an implant failure prior to the 10-year mark. But that's one of the nice things about fat transfers is that whatever fat survives, it's not going to fail. It doesn't need to be removed and replaced every decade. It's just yours there. So that can be a nice alternative to implants. I think one of the biggest downsides to a fat transfer would be the variability with the amount of fat that can be added per procedure. So again, if someone is coming in with really big breasts, you could probably add a lot of volume, but classically those aren't the patients that want a lot of volume. It's usually the patients that have smaller breasts that are wanting more volume, and the amount of volume that you can add in those cases is just kind of a function of how much space it is. You reach a point in the case of fat transfer of diminishing returns, meaning you can't make the tissue plane so tight that the internal or the oncotic pressure within that space is so taut and plump that you're not going to have great blood flow. So at some point, you're going to add so much fat that you are making the blood supply worse and that you're having less fat survive. So as a surgeon, that's not something that we go for. We're going for that happy medium, like full enough that we've optimized the amount of volume that can be added, but not so full that we are negatively impacting the amount of blood flow in and out of that tissue plane. Another myth or misconception is that you can move fat anywhere. You can add fat a lot of places. I think some areas are classically better suited than others. The four that I was talking about before are popular because those tend to be areas that are noticeably problematic when you're appreciating volume deficiencies. You can add fat to a lot of areas, but yeah, usually it's the face, breast, buttocks, and dorsum of the hands. But I've heard some other areas like I've heard people adding fat to their heels. If they stand on their feet all the time, they've lost some of that fat pad on their heel. I've also added fat to areas of like old depressed scars where someone's experienced a trauma and the resultant contour on that site is depressed or irregular. So I see that not infrequently in like the legs, but sometimes even the arms. And those are fine places too, but that tends to be not so much because it's just volume loss from aging. It's more of like a secondary contour regularity from a trauma scenario. Here's some before and afters for fat transfer, including these fat transfer to the face. Fat transfer to the hands, fat transfer to the buttocks, and fat transfer to the breasts. Okay, now we're going to move on to listener submitted questions. So question number 1, can I get a fat transfer and liposuction at the same time? Yes, you have to. So like we touched a little bit on before, in order to transfer fat, you have to have fat to transfer. So that either means liposuction, which is the most common way, but you could also do something like a skin removal. Let's say you did a tummy tuck and you didn't do any liposuction. You could take that piece of tissue with that subcutaneous fat underneath the skin that's been removed, and as a surgeon, I could process that and add it to somewhere. So technically, it's not you having liposuction, but it's like the tissue that you've removed having had liposuction. So that's kind of a gray area with regards to like, are you actually having liposuction? I would say technically no, but we do have to have fat to transfer it in order to do a fat transfer. Next, let's see. Will weight loss affect my fat transfer results? Yes. Yeah. So it's definitely suboptimal to gain a bunch of weight, and especially to lose a bunch of weight following fat transfer, because those cells that are transferred, although they will still be there if they've survived, will kind of shrink down and no longer become as apparent as they were when you had more fat. Next, let's see. How soon can I work after surgery? It depends. So it depends on what kind of work you do. If you have a physically demanding job, and let's just say we do liposuction and fat transfer, then I would say classically 1 to 2 weeks off. I mean, the surgery is minimally invasive. It also depends on probably where you were adding the fat to. If we add fat to the face, it's not that you couldn't go back to work, but your face will be swollen and probably bruised. So definitely there's like a more of a social component to some small extent on the dorsum of the hands, although I don't think that would make people quite as self-conscious if their hands looked a little bit bruised or puffy. The breasts are pretty easy to hide if they're swollen and bruised because people are classically wearing tops at work. The buttocks is a little bit different because if you have any time where you're supposed to be sitting at work, then a fat transfer to the butt would prohibit that. So in those cases, either there's special little seats that you can use, or booty pillows where you're sitting on your posterior thighs as opposed to your buttocks. They also make little chairs that don't require pressure loading of the buttocks as well. You can also do one of those like standing desks too. So there's options and ways to get around it if you need to get back to work and you're feeling good enough to go back to work, but you don't want to sit on your buttocks. You can get creative. I would say if it's a minimally invasive surgery, somewhere around that 1 to 2 weeks off of work would be pretty typical. Obviously, if you are still on pain medications, it's not advisable that you be operating heavy machinery or driving your car, and probably not working either. Okay, so key points. So fat transfer is a nice option for patients that have relative areas of volume excess and relative areas of volume deficiency. The fat that is transferred to the area of relative volume deficiency is a permanent transfer, meaning that the fat that stays is a permanent addition to that area. Again, not every fat cell will stay. For those that are considering a fat transfer, I would certainly advise doing a little bit of research, finding a board certified plastic surgeon that has experience in this area, and meeting with him or her to discuss your goals, meaning like where you're wanting to add the fat, and certainly where would you consider borrowing the fat from. Okay, thanks everybody for tuning in. If you have any other questions or ideas or things you want me to cover in a future episode, visit www.nippeddtoxxed.com and submit a comment or suggestion. All right, thanks everybody.